So we're going to cover a number of things today. The goal, if I could choose it for today, is to leave you with information and knowledge that will empower you, and I hope to enable you and motivate you to have meaningful conversations with people in your family. It is about talking to people. In the end, a piece of paper is just a piece of paper, and it may or may not be helpful. So that's one of our lessons for today. Today we're going to be covering advocacy for your loved ones. The umbrella topic is advocacy, and in order to do that, we're going to talk about a number of specific issues, and those will include when to plan and how to plan, some of the logistics and nuts and bolts of going about the planning process with your family, how you anticipate and get ready for medical decisions. And also advocating specifically for loved ones. When you are in the role of being a representative for someone, how do you go about that? What's important? How do you prepare yourself? We're going to cover those things. And then I'm also going to touch on advocating for family members or loved ones who have cognitive impairment in all of its stages. But really, the whole discussion is going to center around general advocacy and how to create meaningful directives so that you can be empowered to assist your family members. People ask me sometimes, well, how can I avoid having to deal with any of this? Well, you can't. You can get a really rapidly progressive disease and just take a quick exit. But other than that, we're all going to be faced with some of these decisions. When should we plan? People often ask me this question. Should I start planning when I'm 45? My mother's 80. Should I plan with my mother now? My father's 72, but he has heart disease. I'm 65, but I have arthritis. These are normal questions that we all come up with. And we're trying to project a course of illness over time, but in fact, that's only understandable to a certain degree. We also know that accidents and sudden illness occur quite unexpectedly. And how do we anticipate that? So in that context, I want you to understand that the only time to plan is now. So if you haven't started talking to your family at any age or stage of disease, you're really already too late. You're not too late to fix the problem, but you want to start now. It is not something for the future. Sudden illness, accidents, and complications happen every single day. Just pick up the paper and you'll see it. And if we are all lucky enough to be sitting here and being in this room with good health, that is good luck to some extent. How do we make medical decisions? First of all, the easy part is getting organized. Sometimes it seems overwhelming when you think about the illness of a loved one or a progression of disease in someone that you've cared for over time. And getting your mind around the larger concepts can seem very intimidating. So start with the simple things. Be organized. Have the information that you need. Know where it is. You'd be surprised how important that is. And make sure someone else knows where it is. Because if that information is needed rather suddenly for any reason, you may not be the one who can go and get it. And if it's in your locked file cabinet in your office in the second floor of your house, how is your son or your daughter-in-law or your cousin or your sibling going to get to that information? So how do we organize it? What do we do? Again, this type of simple planning will save you so many minutes of grief and distress at a time when you need it, if you just have it in your wallet or your phone or your pocket book somewhere. A stitch in time saves 9 is really one of my favorite sayings. Not only because I'm a physician, and of course we also like to sew things up, and we like to button them up, and we like to fix them up, and we like to put a Band-Aid on it, but a little bit of planning goes a long, long, long way, as you'll see from what we cover today. So what do you need when you start to organize? Very simple information. You all have it. It's just in 10 different places. Make a list of your family members. Make a list of their contact numbers. Make sure you have the new cell phone number. Make sure you have the address and telephone number of your primary care physician and any specialist that may be involved in your care or the care of a loved one. Make sure you have a copy of any existing advance directive. That's going to tell who the durable power of attorney for healthcare is. That's going to say who can speak in the absence of the person, right? And have the medical insurance information. I'm sure you're all familiar with that. It's the first thing they ask you. When I go to the doctors or show up in the emergency department with one of my children, they don't say to me, "Lael, honey, how are you? Well, how do you feel?" They say, "Excuse me, ma'am, please show me your insurance card before you can cross the line," right? So just have a copy of that with you. And if you're the elder or you're the person with an illness, make sure that a copy of that card is with your loved one, with your advocate, so that they can always have access to it when they need to be there representing you. Again, communication is really the key here. Have that information and share it with your loved ones. Empower and enable them to be good advocates for you. How do you really do that? This is the tough nut, okay? Looking at your own life values, looking at the quality aspects of your life that are most meaningful for you. Why do I say that? You may have come here this morning thinking that I was going to give you a list of handy things, and I did give you a nice handout with a list of handy things on it. But the truth is that a list is not going to help you in the end. What is going to help you is having someone by your side who understands you and knows what you care about, knows what you care about in your life, knows how to make decisions for you based on guiding principles that you would choose for yourself. Now you see where the conversation part comes. This is not just a grocery list of medical interventions that you check off, yes, I want that, no, I don't want that, yes to the feeding tube, no to the ventilator. This is about how to make those decisions. And the way that you make those decisions with some peace of mind is going to be based on quality of life for the person that you're advocating for or for yourself if you're educating your advocate. Really is the only ticket to having the right decision made. Another reason that's the case is because the medical world is vastly complex. The number of choices and interventions that you or your loved one will encounter or be faced with or be offered is myriad. And you cannot possibly come up with a piece of paper that will help them navigate through that. They need to understand the values that you want them to bring to the table when they make those decisions for you. That's a conversation you can have. That is a conversation that you and that person can understand. Because you can't sit down and go over all the potential illnesses and all the potential accidents and all the potential interventions and all the potential circumstances. It is just physically impossible to do that. So what do you give them? What pearl of wisdom do you give them to carry forward into the hospital, to your bedside, or with you? You give them an understanding of what's most meaningful to you. So let's talk about advance directives. You all know this term, and you should be familiar with it. What is it? Most importantly, an advance directive indicates who your durable power of attorney for healthcare is. Now, that person might also be called your agent or your surrogate decision maker. Do not be confused by the phrase durable power of attorney, because this person is not your general durable power of attorney. Your general durable power of attorney, whom you may have named in a legal document in an attorney's office, can speak for you in matters of finance and banking and mortgage and so on, and sign your checkbook and whatnot. A medical durable power of attorney or a durable power of attorney for healthcare does not need to be established in a legal setting. You do not need an attorney to designate this person. In the state of California, you can designate a healthcare agent by having 2 legal witnesses or have it notarized. and you just write down, I want my sister Jane to be my durable power of attorney for all my healthcare needs. You can do it on the back of an envelope. Now, I hope that you choose a nice piece of stationery or write it out on a clear piece of paper, but you could do it on the back of an envelope and take it in and have it notarized, and that would be valuable. Okay? So, it's very easy to name someone, and that's what an advance directive does. Now, an advance directive may or may not contain an indication of your choices. Now, when I say choices in that frame of mind, I mean medical choices. Choices about care. Choices about organ and tissue donation. Choices about your burial or cremation. Choices about whether or not you want to be in the ICU or not, or receive CPR or not. Some of that information may be in an advance directive, but it isn't necessarily in an advance directive. Okay? So again, a little more terminology. Just to summarize, a legal advance directive, which you don't need an attorney's office, you don't need to pay anyone to do this. It authorizes someone to speak for you in matters of medical decision making when you cannot speak for yourself. Secondly, it may contain information about choices in care that you wish to convey to your medical team. Living will is a different kind of document. It usually refers to your durable power of attorney for health care. It may legally authorize that person, but usually doesn't. It is a document that is specifically designed to talk about your wishes for care. Sometimes they're just a letter that people write. Sometimes it's a big long form that they filled out in someone's office. A living will is meant to indicate the types of care that you would want under certain circumstances. Please note that I have already explained to you that these documents are problematic. Why? Because that list cannot possibly cover all of the potential complications and issues that can arise in a medical setting. It is not going to address what happens in the gray zone, where there are lots of ifs or what ifs, and a lot of uncertainty about the outcomes. And remember that no matter what you write down on that document and how meaningful it is, you are not there to explain what you mean when someone is looking at that document. The only reason someone needs that document is because you cannot speak for yourself. So I'm asking you to go beyond writing things down. I'm asking you to have the meaningful conversation with your family that will allow them to make judgments and decisions for you based on the quality of life that you wish to maintain in your lifetime. I also want to talk about the POLST document briefly. How many of you have heard of this document? Okay, small show of hands. Physician orders for life-sustaining treatments. This is a new form in the state of California since 2009. It was first pioneered in the state of Oregon. There are many other states coming on board. There probably will be in the next 5 years a national POLST program. In some states it's called something different. It might be called medical orders for life-sustaining treatment. What is unique and different about this particular form, a couple of things. One, it's usually an addendum to an advance directive. It is only indicated, or it's only necessary for certain types of people, and I'll describe that. It is very, very special because it is a physician's order. It is signed by a doctor. Okay? So it is a physician's order that is transferable between healthcare institutions, from the doctor's office to one hospital to another hospital to a nursing facility and back and forth. That is brand new since 2009. Before that, every time you went to a new facility, whoever your doctor was there had to write a new order for you about things. Now, you still have to restate your wishes anytime you're admitted to the hospital. I'm sure you all are aware of that. But what the POLST document does is protect your rights in certain situations. So who gets a POLST? POLST is indicated for anyone who's quite elderly or frail for any reason, or anyone with an advanced medical illness. Heart condition, lung disease, late-stage kidney disease, anyone for whom catastrophic illness or death or complications of their disease is considered to be something that might happen within a time frame of 6 months to a year or so. Okay? So it's really for a very particular population of patients. Why is it important? It's important because if you don't say what you do and don't want, everyone is going to guess. Now, do you want people guessing about what kind of care you want when you're desperately ill? I think maybe not. Now, a lot of people get intimidated by a form like this because it addresses issues of CPR and resuscitation and ventilator and so on. It is not a form just so that you can say no to those things. It's not a form just for people who don't want those interventions. It really is a form for everyone who might ever be considered for those kinds of interventions. Because when you have this form and you show up in trouble in some way, the doctors and the medical team immediately know how you want to be treated. They are going to be more confident moving forward with your care, knowing what you want, whether it's a yes or a no, rather than not knowing and making a guess. Okay? Because the guess is what happens in the default situation. When there is no knowledge, we proceed in a certain direction. And in the medical world, what are we trained to do? Treat, right? We diagnose, we treat, we do interventions. So if you don't say what you do and don't want, what you do get is all of the treatment. You may want all of the treatment. You may want some of the treatment. You may want some treatment until it's really not working, and then you may want to call it quits. The only way that you're going to get that quality of care that's important to you is if you indicate to your loved one some means of making these decisions. And the PULSE document is one way to clarify those very particular wishes for frail elderly patients or for patients who have significant medical illness. It protects them from either getting or not getting one thing or another thing that they either do or don't want. And it brings peace of mind for the family and also, and speaking as a physician, for the provider. If I have an unconscious patient that I know is very elderly and very ill, maybe late-stage cancer, in their 90s, now this person is going to die soon. And I have no indication what kind of treatment they want. And they come in and they need all types of interventions. That is not going to be comfortable for that person. It's not pleasant. I would surely like to know that I am treating them consistent with their wishes if I'm going to be doing things that may not be pleasant or that might be traumatic for the family as they watch their loved one perhaps suffer or linger or whatever term you want to consider. So it's a protection for the patient, for your loved one. It's also peace of mind for the family. Surprising fact, right? Advanced directives are not helpful. Why? Most average advanced directives that are available today, right now, pardon me, not that are available, that are owned or that people have, are not helpful because they haven't been filled out in a thoughtful way. All right? Now, either they don't exist, which you may be surprised to know is true for about 75% of Americans or more. They simply don't have one. Or the durable power of attorney was named so many years ago, or the durable power of attorney for healthcare was named so many years ago that that person isn't a match for the person anymore. Maybe they're already dead. Maybe they're doing research in Tanzania. You know, maybe they have become estranged from the family. Maybe it's a spouse that's now divorced or separated. So if those documents are too old and they haven't been reviewed, the durable power of attorney for healthcare that I'm going to call when I say, I need to put a feeding tube in, do you agree to this? They're going to say, well, I don't know anything about what's going on. That's not helpful. Okay, so that's not a helpful advance directive. The other reason that they're not helpful is because they really don't contain meaningful information about how to make decisions for this patient. And here again, I'm talking about quality of life. They may say, and many of them say something like this: if I'm terminally ill, do not perform extensive life-sustaining treatments. What is wrong with that sentence? Well, let's take the word terminal. What does that mean? I might be diagnosed with pancreatic cancer tomorrow. That's a terminal illness, pancreatic cancer. But I might respond to treatment and be alive in 10 years. Or I might have rapidly progressive disease and do very poorly and be terminally ill and die within 6 months. Okay? Now, I might be diagnosed with Alzheimer's disease. Now, Alzheimer's disease is eventually a terminal illness. It leads to a steady decline and loss of function. It's associated with medical complications. When do we say that's terminal? Do we say it's a terminal disease when you get the diagnosis? Do we wait until something happens? So just the word terminal doesn't help me. How about life-sustaining treatments? That was the other half of that sentence. Well, what does that mean? I mean, I'm breathing air. That's sort of a life-sustaining activity that I'm doing. Life-sustaining treatment, maybe I'm just giving someone with lung disease a little bit of oxygen. That's going to keep them conscious. That's life-sustaining for them, but it's not very aggressive treatment. Maybe, on the other hand, they need a ventilator. Well, that's aggressive. We would probably all agree that that's life-sustaining. So you see what I'm getting at? It's a big gray zone. And what you think is life-sustaining and aggressive may not be what I think of life-sustaining and aggressive. And how do I read that into a document that's just typed up in black and white? I can't. If you do nothing else, choose a good durable power of attorney for healthcare. Make sure you have the right person by your side. Make sure they have the information that they need, at least from a logistical standpoint, and do your best to communicate your values. So how do you choose that person? And I want to talk specifically about loving in this setting. We tend to choose, for our durable power of attorney for healthcare, our spouse, our oldest child, our sibling. And as time goes by, we may need to rethink that. If I choose my older sister and we both live into our 90s, she may not be available when I need her, so I need someone younger at that point. All right? How about the situation of love? We love and care for the people that we love and care for. And we often trust that they will have our best interests at heart, which they normally do. But think for a minute about what might be challenging about that situation for someone who loves you so much. Love and deep, deep, deep emotion can cloud your judgment. They can make it difficult for you to decide in a very tense situation what to do or what not to do. Some people will be able to remain rational and comfortable and proceed according to your wishes, regardless of how desperately upset they are. Other people will have a harder time. I've seen this especially with couples, where it's maybe time to let go. Maybe there's almost nothing we can do anyway, and it's time to let go. And the spouse who's the durable power of attorney for healthcare just, it's just too hard. And it is too hard. It's impossible. So think about that. You want someone who's going to love you and care for you, yes, but also be able to make difficult and rational decisions. So what are the qualities? Again, from a very simple logistical perspective, how do you choose this person? Think about these qualities. It's just a checklist. They need to know you really well. They need to be able to advocate for your choices in a stressful setting. They need to make difficult decisions in a medical setting. The person should be available. Don't choose your brother who's doing research in Antarctica. Or if you do, make him the second person and have somebody else nearby who's available. Choose one person. So many families that I've worked with, they've got all 5 of their kids on the same line. You know, consensus decision making when you're trying to work with a medical team in a complex, urgent setting doesn't work very well. And I'm going to call 5 people at 2 a.m. in the morning just to see if I can put an IV line in. That's not helpful for you. That's going to delay your care. All of those people that you love and care for and respect can certainly be involved in the decision-making process. They can be listed as numbers 2, 3, 4, and 5. Okay? And you can tell them and teach them that, yes, I'd like for you all to participate in the decision-making process, but when it comes time to actually speak with the doctors, so-and-so is going to do it, just for clarity. And that person will have the final word. So choose the person that you want to have the final word. Okay? Now, that can be difficult in families because people are sensitive about not hurting other people's feelings. They don't want someone to feel left out. So one way around that is to give other individuals different roles. Make one person the head decision maker, whom you know is your primary advocate, will interact and speak with the medical team. Give the other people other roles. You are going to be my emotional support. I really want you to be at the bedside with me if I'm really frightened and ill. You are going to be the logistician. You're going to, make sure that my husband or the other kids are fed and taken care of, and make them a team for you. But in terms of your medical well-being and your medical decision making, please have one person as your primary and then the others listed as secondary. Also, think about whether or not they have conflicting values and whether or not those values change over time. What is your name? Adrian. Let's assume for a minute that Adrian and I are sisters and we love each other and we're the only ones in our family, and she's my advocate and I'm her advocate, and we're, happy and healthy and everything's great. But we don't live in the same city. And she goes off to India and she travels around, and then she goes to university, and when she comes back she tells me that she's decided to be Hindu and also follow Christian Science beliefs. Okay, so her ideas about serious medical care and end-of-life care are now going to be centered around the concept of her soul being reincarnated, and also the fact that she does not like a lot of medical intervention. She believes in the body's ability to heal itself, and she believes in that power within the body and the spirit of the universe to take care of her. And she's very confident and comfortable in that belief. And so she has told me now, okay, if something really serious happens to me and I'm need to be taken to the hospital and maybe my heart's going to stop or something happens, she says, don't let them do anything. Just let me have a nice, quiet, peaceful death. Whatever happens, I'm very accepting of that. It's okay for me, and I'm comfortable with that. And I say, Adrian, wait a minute. I know you had a great time in India, and I get it. Sometimes medical devices can be scary and everything, but I'm a born-again Christian now. And to me, my idea is that life is pure and sacred every moment of it. And every moment that I'm alive on this earth is something special and sacred to me with my God on this earth. And I want to be in that position as long as I possibly can, whether I'm conscious or not. So if I get really ill and something happens, if I'm hit by a bus or I have bleeding in my head or something terrible, I do want treatment. I want to go to the ICU and I want to have them put the IV lines in and keep me alive because my life is so precious to me here on this earth with my God, and I want to be alive as long as possible. Now, my view is perfectly valid, and Adrian's view is perfectly valid. They're both real, beautiful, personal choices, but they're very different. So we either have to come to an agreement about our ability to advocate for one another, even though it might go against our central beliefs, or we have to choose a different advocate who is not going to be so conflicted, right? So the choices that you talk to your advocate about should reflect your quality of life. So in my discussion with Adrian, it's not about what they're going to do to us, whether that's CPR or go to the ICU or be on a ventilator for a day or a week or a month or a year. It's not about what those choices are. It's about the quality of life, the quantity of life. It's about what we hold as valuable. I hold valuable, according to my pretend scenario, that a life, even if I'm truly unconscious and incapable of interacting with the world, is still valuable to me. Adrian doesn't feel that way. She wants to be conscious and participating in the world, and that's valuable to her. And when she can't do that anymore, it's okay with her if she dies a natural death. Those are values that allow us to make care decisions. Now, that's an extreme example. So let's look at a milder one. Maybe you fall and you break your ankle. So maybe this gentleman has fallen and broken his ankle, and he says to me, Lael, fallen and broken my ankle, and you know, I'm still working. I'm working, and I've got a job, and I'm a salesman, and I have to go to the businesses. I got to walk in and out. I got elevators. I got the books to carry. I got everything. What can we do to fix my ankle? I said, well, you know, that's a bad break, but we can pin it, and we can do some surgeries, and then it's going to be probably 6 or 8 weeks of rehabilitation. And how do you feel about that? He says, well, I really, I don't have a choice. It's my quality of life is really important to me, and to me, I got to be out. I got to get my job back. So I'm really gung-ho for this. Okay, great. Broken ankle. We're going to pin it. We're going to do surgery. We're going to do weeks of rehab. He's going to need, some pain medicine, and he's going to be walking in a cast and the whole deal. Now, what about somebody who's 89 and has really terrible arthritis and is in a wheelchair anyway, and she falls and breaks her ankle? Different situation. Her quality of life is already quite different, and she's in pain. The ankle's very painful, very painful. So maybe in this situation, we choose to do whatever we can to alleviate the pain, because we know she's probably never really going to walk on that ankle again. She's already wheelchair bound, but we can't leave her in pain. So we're going to do surgery to alleviate the pain, and that might mean pinning. It might mean the exact same surgery or not, but we're not going to go through aggressive rehabilitation and casting and lots of extra x-rays and things, because we don't need to, because those things are not going to reach a goal that's important to that patient. His goal, I've got to be mobile again. Her goal, I need to be out of pain. Same medical problem, different goals, different focus on the intervention. You see where I'm going with this? Now, I know that for me, this says the survival of this patient is a testimony to the blessings of modern science. Now, I know for me, I would never want to be that person. But we all know some people like this. We know people who literally want to live forever. And you may not know it, but I'm sure you've met people who actually think they are going to live forever. And there are people who write about wanting to be, cryo-frozen or whatever and come back in 200 years. I mean, it takes all kinds. Everybody has a different idea, right? Share your idea with the people that you love so that they can represent you when they need to. Why? Last time I checked, and I'm not a brilliant statistician, but I'm fair. I'm pretty good. I can look at some things and understand what goes on here. Last time I checked, we were all human, and as far as I know, we will all at some point face either illness or disability or death or all three. And there's really no uncertainty about that. 100%. Now, how often do you get to bet on something that is 100%? Not very often. So take the opportunity to bring some good out of something that you know 100% is going to happen. Whether that's some form of illness or ultimately your own death, those things will come and your family will be affected, and you can, through planning, give them some peace of mind and some tools and some emotional resilience to deal with these issues so that they are not traumatized by complicated bereavement or guilt or other feelings that are not justified but will come to them because of the stress of the situation. So who is that guy? You know, death, it's coming. I'm sorry, I could walk out of here and be hit by a bus. Give the gift to your family of knowing what your values are. It will help them immensely. It will help you immensely. Don't roll the dice on this. Would you want to take chances with the amount of pain you're willing to endure? With the amount of chemotherapy side effects that you're willing to tolerate at a time when you can't speak for yourself, with the number of surgical interventions you might ever want to have. Because it's not about those interventions, it's about what doing those things brings to you. What is the goal of the treatment? How is that going to help me? Is it going to help me reach my goal of either being pain-free or mobile or cognizant? Now this one is pretty blunt. Step aside, they're still doing CPR. Here's the lineup at the pearly gates, right? I put this up there because it's a reminder that someone near to you, someone you love and care about, may be secretly hoping, or maybe not so secretly hoping, for a peaceful death at some time in their life, at the end of their life, actually. But when we survey people, oh, how would you like to die? Everyone says, oh, I'd like to just go in my sleep. News for you, that is not what happens. Because if you happen to pass out, somebody's going to call 911 and you're going to go to the hospital. So if you have any idea that either you or someone else you know might want to die peacefully in their sleep, boy, oh boy, you better plan for that. You have got to tell someone, and you have got to fill out a post form and stick it on the refrigerator or on your bedside. That's where it's supposed to be. And keep a copy in your wallet always. There's no guarantee. You could be in Safeway by yourself and have a bleeding aneurysm or a heart attack, and they're going to call the paramedics, and you're going to get CPR and go to the emergency department. But by the time you get there, who are they trying to get on the phone? Your advocate. And your advocate is going to say, my mother has a post form and she did not want CPR. Can we please stop what you're doing and make her comfortable? I'll be there in a minute. Or let me talk with the physician. Or I think what we're doing right now is not going to achieve a goal that's important to my mom. So let's rethink it. Let's take a step back. Okay? It's really important that the choice is yours. It helps the physicians. It helps your family. It's not important to me whether you want to be kept alive forever in the ICU, although it is, at some point that becomes what we call medical futility, and then there is eventually an end to that. or if you choose to have a pulse form that says, I never ever want to have CPR. I just want to know that I'm treating you respectfully and with grace in a way that you want to be treated. That's what's going to make me feel good about your care, and that's what's going to make your family feel good and empowered about your care, knowing what you want. So be informed and choose wisely and communicate those wishes, particularly with respect to resuscitation. That is the big one. Most young people feel that they would want to have resuscitation. Some older individuals feel that they would not want to have resuscitation. Most of the general public don't really even understand what resuscitation is. That's part of the problem. So resuscitation is an intervention that was designed to keep a dying body alive while it is transported or taken to a place or put in a position to receive some kind of treatment that would hopefully reverse the process that caused that person to collapse in the first place. Okay? CPR and resuscitation, chest compressions and putting the ventilator in and all that is not a curative treatment. It's a sustaining treatment until a diagnosis can be made. And if that diagnosis happens to be something reversible, then perhaps a treatment can be given that would allow that life to become stable again. In the absence of that treatment, death would naturally occur, right? So you can imagine, and I'll give you two different scenarios to think about. If you're a 55-year-old male who's really fit, but there's a family history of heart disease, and maybe you've got one blocked artery in your heart and you don't know about that, and you're running your 5 kilometers a day with your running partner, and you have a heart attack and you collapse because your heart has had a blockage and starved for oxygen, so it's gone into what we call a fatal arrhythmia, which means an abnormal heart rhythm that will lead to death, and your running partner happens to know CPR. Maybe he's even a paramedic. So he immediately begins CPR. So zero downtime almost. CPR, and he has his cell phone. So he's doing CPR and calling 911 at the same time. And miracle of miracles, paramedics arrive in 2 minutes. Unheard of, right? So now you've been collapsed. You've been collapsed for 2 minutes, and you've had CPR for 2 minutes, and already the paramedics are there. And shoop, in goes the tube, and they get the EKG, and they put you in the ambulance, and they say, whoa, we're looking at the heart tracing. It looks like this guy's having a massive heart attack, and they get everything ready, and they shoot you into the ER, and they take you right up to the cath lab, and they put the catheter in, and they open up that blockage, and 5 hours later, you're awake, saying, well, what the heck? What happened? And you don't remember any of it, but you're awake, and your brain is still working because somebody was pushing blood up to your brain until that situation could be stabilized and reversed. That's the best case scenario right there, okay? Single disease process that is reversible has led to a sudden fatal event, and the person got immediate rescue. Now, if you look at generally the patient population in the community, people who sort of collapse on the street from a heart attack and a heart rhythm, just on average, provided they're in even, usually reasonable health, and they get to the hospital and they get some kind of treatment for that heart problem, the chance that they will wake up and completely resume their normal life as they were before varies depending on the studies that you look at, but 35, 45, 55%. That's the best case scenario. Maybe it's even 65%. That's the best case scenario. Everybody else has some kind of permanent damage, or maybe they didn't make it at all. Now, I would like it if that was most of the time that we did CPR, but it's not. Why is it not? Because most of the time we do CPR, it's on older, more frail patients who are sicker, because those are the ones that collapse, right? They are naturally heading towards a precarious time in their life when they're more fragile, they're more likely to have some kind of potentially fatal event. So in that situation, worst case scenario, very elderly person, late 90s, in a nursing care facility, already disabled so that they're not independent enough to live at home. They're weak, they have perhaps multiple types of disease processes, maybe a little bit of heart disease, maybe some lung disease or kidney, or they're recovering from pneumonia or something, and they're weak and they're frail. If that person collapses and is having a natural fatal event, and they receive CPR and get transported to the hospital, the chance that they will be able to resume their life at that nursing facility in same or similar condition is now less than 2%. And usually they're in a worse condition after, pretty much uniformly, if they survive at all. That's the worst case scenario. So CPR doesn't save someone who is having a natural death process from multiple other things at a very advanced age. It will allow them potentially to survive longer. Likely their quality of life will be reduced. Now that's not universal, and we always hope for a good outcome when we do these things. We never know when someone collapses why they've collapsed. Maybe they're just choking and they got starved for oxygen and their heart stopped briefly and they get CPR and they stop choking and they wake up and, whoo, okay, that was a lucky one. And we never know. So based on that level of hope, a lot of people would choose, well, I really would want to be resuscitated because I want them to keep me alive at least long enough to know what's wrong. But in these more complex situations, what we usually find out when we get to the emergency department is a lot may be wrong, and we're not quite sure, which thing caused the apple cart to tip over. But what we can be sure about is it's going to be almost impossible to get that person back to the quality of life they experienced before. And I am talking about full resuscitation here. Heart has stopped and breathing has stopped completely, okay? Not somewhere in between. So I know that that's difficult news to swallow in some respects, but I think that you deserve to have that information in order to protect what I consider to be the most valuable thing, which is your quality of life and the sanity and dignity of yourself and your family during a difficult time. So how to do this? Do it on your own or with your family. You can use a professional facilitator like myself. We're rare and far between, but we do exist. You can do this online. There are some wonderful new programs available that will actually help you have these conversations. They will give you vignettes, videos, dialogue, sentences, all kinds of things to use. So please explore the resources that I've given you. And see what's there for you. The conversationproject.org is wonderful. It's family stories. Doing this kind of conversation at your kitchen table. And again, the conversation is not just about end-of-life care and death. It's about quality of life. It's about making things meaningful. All right, so knowing all of that information, as difficult as it may be to get from your loved one, as tough as it might be to talk about, is going to really empower you in your decision-making process. It will bring you peace of mind. It will bring you a lightness of heart. I say that because I've worked with families, and they just feel so much better when they know that they're really speaking to the wishes and goals of the person that they're advocating for. So how do you advocate when you are the agent? You need to, just like we said earlier, you need to be organized and have the information. You need to keep a calendar and be up to date. You need to have the insurance information. You need to have a copy of the legal directive. These are just basic logistical things that will free you to navigate through the healthcare system with a minimum of encumbrance. What else? Always prepare your questions in advance. For any physician's visit, for any time that you're waiting at the hospital with someone and the team is going to be rounding, whether it's the physical therapist that you need to talk to or the physician or the consulting physician, have your questions in advance. If they are rushed and they are not able to address them, just say, I have some questions. When would be a good time? Would you like a written copy of them? Can you get back to me? Can you have your associate get back to me? You won't know the answers if you don't ask. And yes, physicians and medical staff are very, very busy, and they are rushing around, particularly on morning rounds. They've got to get through all that stuff, and you're waiting there. You've been waiting for hours and hours, and they finally show up, and you didn't even know what time, and they come in the room, and they take 2 seconds, and then they're ready to run. Just say, I really have some questions. Can you get back to me later? Okay? And ask the right person. It's okay to say, I need to know about mom's discharge. Who do I talk to? I want to know if mom's ready to climb the stairs at her house. Who do I talk to? They'll help you. Ask the right person the right questions. Be present. Don't go to the hospital alone as a patient. Just don't be there alone. You've got to have someone there with you, particularly for older people or someone with disease. Their sleep cycle gets disrupted, they're on medications, things have changed, they might be in pain, they might be physically or even mentally able to make decisions for themselves, but it's exhausting and they may be confused, they might not remember. Really important to have an advocate at your side when you're at the hospital, pretty much all of the time. I wish that weren't the case, but it just is. It just is the case. Ask questions again. Know which questions to ask and ask them. So what are the questions to ask? What is the goal of this treatment? We think your mom needs her gallbladder out. Well, why? Is it going to help her? Is it going to take away her pain? What if we don't take it out? Then what? I think that question is great. People forget to ask, what if we don't do anything? What if we just choose no? You'll get a lot of information if you ask that question. And then compare that to what happens if you choose yes. And see which one brings you ultimately closer to a goal that is meaningful for you and your loved one. Because they might take you completely down separate pathways, or they might actually lead you to a similar goal. And then you're comparing apples to apples, and you may feel differently about that. But you won't know unless you've explored those other avenues. Physicians are famous for recommending what they think to be the best course of treatment, but they don't know you like you know you. And what's the best course of treatment that leads to a possible cure might not be what you want. What if the treatment is painful and the chance of cure is 40% and you're 98? Are you going to take a painful treatment for a 40% chance of cure and you're 98? Just depends on how you feel. You might be the kind of person who says, yeah, ready up, let's go. You might be the kind of person who says, no, that much pain in that treatment, I know that my time is coming soon anyway, and I'm just going to take my chances and no thank you. Your choice, your life, your values. Most important. And you see how it may change what medical choices you make. It's not about how effective the treatment is. It's only about how effective the treatment is if you want a cure. Right? What are the risks? What are the benefits? Are those benefits important to me? How do I get there? What will make it more likely that I get there? What will make it less likely that I get those benefits? What are the other choices? Always, always, always ask whether or not the treatment in question or the plan or the transfer or whatever you're considering, is it consistent with the goals, the longer term goals, whether that's a return to mobility in the case of pinning the broken ankle, or if it's trying to cure a cancer in someone who's 55, or if it's trying to relieve cancer pain in someone who's 85. What is the longer term goal? What is the big umbrella under which you are making these decisions? Your life. Know your patient rights, right of review for discharge. If you're a Medicare patient, if for any reason the family feels that the discharge is unsafe or truly unreasonable, they have a right of review. Now, you will be discharged ultimately. This will happen. But at least you get an extra 24 or 48 hours to consider it and to get yourself on a waiting list for another nursing facility or to do whatever else your family needs to do. Now, the hospital has to discharge you appropriately when a bed is available at a reasonable facility, and they will do that. The other option is you pay privately. If you happen to have funds and you really are not comfortable taking your loved one home yet from the hospital or the nursing home or whatever, inquire about private pay. There are people there that are going to be happy to take your money, I'm sure. Who isn't? So ask the questions. Second opinions, always a good idea. I say second opinion for any serious diagnosis. Don't worry that you're asking within the same hospital setting. You don't even necessarily need to worry if you're asking two physicians who work in the same practice, because physicians generally have a high enough integrity and enough ego that they're going to give you their best opinion regardless of what their colleagues said. And if the opinions align, great. If they don't align, they'll find a way to communicate that to you. And if there's really still a quandary, get a third opinion. That's usually not necessary. But always get a second opinion about something really serious. Also, you are entitled to reasonable care that's consistent with your goals. So if you are, for example, a Jehovah's Witness and you do not want to accept blood products, and you've been in a car accident and you come in and the surgeon says, we've got to transfuse you because I have to take you to surgery and you've lost so much blood, I think you may die unless we give you blood. And you say, well, I can't accept blood. And this happens. And the surgeon will say, well, I'm not taking you to surgery to try to fix you if you won't receive blood when we're in the OR. Then you say, all right, get me another surgeon, please. You are entitled to that. You are entitled to reasonable care that's consistent with your goals. As an advocate, be aware of the high-risk times. This is primarily any time there's a transition or a change in the care plan or location of care, right? Admission, discharge, transfer, especially. And medication errors, they just happen. If you write down the same med list 10 times and 10 different people look at it and 4 different pharmacies review it, something's going to happen. So just be sure and be careful. And as an advocate for your loved one, be aware that those are difficult and dangerous times. That your loved one is going from a team that knows them pretty well to a team that may not know them at all yet. And you really need to be present to convey to them what needs to be conveyed, which may be your loved one's wishes and goals, or it may be some of the history of what has recently happened, or it may be the fact that they really did have a bad drug reaction to some antibiotic or other. Be present in those danger times. Now, advocating for patients or loved ones with cognitive impairment. So cognitive impairment runs the full spectrum from very mild, minimal problems still functioning quite highly in society to completely dependent, absolutely checked out from society, may not even recognize family members, and total dependence for all care. Okay? So needing to be fed and bathed and toileting and everything. That is a big spectrum. Now, all of us would feel differently about how we're interacting with our families and what's the quality of our life and how meaningful that is for us at different places along that spectrum. And it's going to be different. Adrienne may choose different places on the spectrum where she feels more or less comfortable than I would choose, or anyone else in this room. But because we're getting so good at treating heart disease and cancer and a lot of these other things that used to wipe us out 100 years ago, cognitive impairment and other age-related disorders are becoming more and more prevalent. We are living through the other diseases and living into this last phase, which is very common now. So almost 1 in 8 people over 80, at least, will suffer some form of cognitive impairment. And planning becomes essential. It's never, never too soon. At the first inkling of any cognitive impairment, whether it's disorientation, getting lost, early Alzheimer's, memory problems, begin the planning. Remember I said at the beginning, when do you plan? Now. Now. So I want to put this final phase of many people's lives into a little bit of a context. I want you to understand, on average, what may happen in disease, because it's very different when we talk about frailty and dementia. For example, with cancer, and this is average, this is not everyone, this is just average, okay? People get diagnosed at a time, they usually have a screening test or something, and they get diagnosed, they're very healthy and functional at that time. So on the left side of that graph there, you see very high function, high quality of life. They get their treatment, kind of bumps along, this graph doesn't show it, but there's usually some little bumps in the road as they get their chemotherapy or their surgery or whatever, and then they either get cured and they go on high functioning, high quality of life, or the cancer comes back and it comes back really bad. And then they usually don't have that much time. They have a certain amount of suffering and then they die, right? So that's just average. What about organ disease? So these are patients with late stage or advanced lung disease or late stage or advanced heart disease or maybe end stage kidney disease. Now they've already lost a lot of function, you see, on that side of they lose function because something isn't working right. So they're less independent and they have a kind of a rocky road because organ disease tends to either flare up or decompensate at times, or you get complications. So we're in and out of the hospital and things are happening. And then every time one of those sort of exacerbations occurs, you try to get back up to that baseline, but often you don't quite make it. You don't quite make it back up to that quality of life and function that you had before. So you sort of slowly go down, and you never know which one of these really bad-looking flare-ups is going to be the final, right? We just don't know. We just don't know. Could have been this first one, might be this third one, might be the 10th one. We never know. But one of them is going to get you, right? It's a coming. Now, frailty and dementia, now what's happening? Function and quality of life go down, and then you live a long time if you don't have any other disease processes. Why? Because we're really good at treating things. We can treat pneumonia, what they used to call old man's best friend. We can treat pneumonia, we can treat heart attacks, blood pressure and urinary tract infections and all kinds of things. Now if we treat those things, then you stay alive with your frailty and dementia for many, many years. This is the standard of care now, I think, and this is what many families and people choose, is to try as best as they can to maintain the quality of life for the patient and for their loved one. What I want you to think about for yourselves and your loved ones is there a point along this line when you would say, that's enough for me, whatever the next bump in the road is, just let me go. Let me have a natural death process at some point in time. So this one shows if you happen to have frailty and dementia and organ disease at the same time, it's just a rockier, tougher road. And then you're hospitalizing and doing more significant intervention on a person who is less physically able to tolerate it and less mentally capable of understanding it. Which may be their wishes, may be important to them, maybe not. Why do I show you these? I show you this because prognosis for life or death is always uncertain. Doctor said I was going to die in 6 months. Here I am, 10 years later, looking good. Right? Doctor said I was going to die in 6 months, and now he tells me I'm going to be dead by next week. We never know. We never know. It is not up to us. We treat and we try, and we can look at statistics. I can tell someone that they have a 67% chance of a cure of their colon cancer. But maybe they're in the other 33%. I don't know. I can tell someone may have a 95% chance of recovering from a heart attack. Maybe this guy's in the 5%. I don't know. We try to look at things that will help us predict. But the truth is, we really cannot know, because everybody, every soul, every person is a little bit different, with a different fighting spirit and a different will to live and a different agenda and a different set of life values. What I want to do is treat that person the way that they would want to be treated if they could tell me. Cognitive impairment does not prevent you from participating in advanced care planning. So patients with cognitive impairment can participate. The more advanced their disease is, the more confusion or disorientation they have. It does get trickier, maybe impossible. What I recommend is that you have someone with you who understands that process. So that would be a neurologist, a psychiatrist, a dementia specialist, a physician, somebody who can help you interpret as a family member whether or not your loved one is really perceiving and comprehending the things that are being discussed. You also want to look back at the way that person lived their life. Typical story I hear is, someone has lived their life avoiding medical care. They never wanted to have their blood pressure treated. They were totally, just kind of anti-care, independent, wanted to live at home, do their job, and then something sudden happens, and then their advocate is advocating for very, very aggressive care. That may not be what that person would have wanted. Impossible to know now because we didn't ask. Advanced care planning, it really is the most important thing. Really, really it is. And it's not a grocery list. It's not, yes, I want the ventilator. No, I don't want the ventilator. Yes, I want a feeding tube. No, I don't want. No, because you don't know the setting in which those things are going to be offered to you. So what you need to convey to your advocate is what's the quality of life that you want to have maintained. What's important to you. Freedom from pain, mobility, physical and emotional interactions with your children, ability to write a book, finish a memoir, ride your bicycle to the store on Sundays. Whatever are the things that are really important to you that you want to maintain and hold on to, that's what you need to tell your family about, so that they know if the 7th round of painful, nauseating chemotherapy is going to get you to the place where you can ride your bicycle on Sundays, great, let's consider it. But if not, maybe that is something that you would not choose. Maybe you would like at that point to allow the natural disease process to progress. You need to share that. This is a gift. This knowledge is a gift for you and for them. It will bring peace of mind for your family. It is a beautiful, beautiful thing to allow someone to have some kind of a transition that they envisioned for themselves. It is really powerful, really, really wonderful. It does not have to be what people call it a battle. at the end of our lives or through any serious medical illness. It can be a thoughtful process where we're keeping in mind someone's quality of life and the values that they hold dear. And you can always reevaluate. Just because you start down a path, if things are not going in a good direction, you can take a step back. You can change directions. It's okay. You just ask. And if you know truly, and you've had conversations with the person that you're advocating for, you will be empowered to do that. And you will be able to make difficult decisions for them without the grief and angst and fear that you would otherwise have. The angst and fear and grief that is normal in those situations in the absence of any guiding knowledge. So give your family the gift of guiding knowledge. Give that gift to yourself. Ask the right questions. Don't just ask what can be done, because we can do an awful lot. And I'm not sure that you want that or I want that. But if you want it, I want to give it to you. I just want to know that you want it. Understand the goals of care. Know that palliative care is always available. Palliative care physicians are specialists in symptom management. Any stage of illness, they help put things in perspective and focus on goals of care and quality of life. They can be asked for consultation anytime. They're available in most major hospitals. Hospice is care in the last 6 months of life. It's an insurance designation when a physician feels that you are likely to die within 6 months approximately. You become eligible for hospice care, which is a designated set of benefits that includes particular types of nursing services and social support services for your family that may be terribly beneficial. I have seen many people graduate from hospice. Just because you go on hospice does not mean that you will die in 6 months. Why? Because we never know. Remember, we never know. And if your loved one is benefiting from hospice services, but does well and graduates, maybe accidentally, from hospice services, you can get reevaluated at any time and have those services reinstituted. Just ask the questions and know what your options are. In the hospital, your care manager or your discharge planner, one of your best resources for questions about insurance, discharge choices, who's on the team, who to talk to about different issues, and there really can be a good source for you. So, I hope that you will be encouraged, motivated, and empowered to do this type of planning for yourself and for the people that you love, knowing that it will relieve stress, decrease depression and grief and bereavement, and it will bring peace of mind and to often a sense of life and increased livelihood. Because there's a little bit of worry that goes away when you know you have a little bit better plan in place, and people feel more alive with that. I thank you for your attention, and I'm happy to take any questions.